Welcome to Raaonline. This is Dr. Lavanya. Today I'm going to talk to you about cardiovascular medication poisoning in children. The objectives of this topic will be about the etiology of the poisoning, the pathophysiology, the labs, the management and the antidotes. Okay, so the medications to be discussed in this will be about beta blockers, calcium channel blockers, clonidine and digoxin. So now from the first thing about all these, what is the source of ingestion of these medications? In children, commonly it's accidental ingestion by exposure to adults' unattended medications. It can also be, some of these medications can also be used in children for certain issues that they have, and they can also accidentally take excess of these medicines because they might be very colorful. In adolescents, it can be because of unintentional intake of the medicine. Okay. So the first thing we are going to talk about is about beta blockers. So beta blockers, first be discussing about the pathophysiology, because how these act will show what will be the complications that can occur when there is an overdose. So in beta blockers, you have, they mainly act on the beta 1 and beta 2 receptors, which are present in the heart and the peripheral blood vessels as well as in the lung. In beta blockers, you have selective and non-selective beta blockers. So the selective beta blockers act mainly on beta 1 receptors. Example of selective beta blockers are atenolol and esmolol. The non-selective beta blockers act on beta 1 and beta 2 receptors. The non-selective beta blockers also have other uses. The commonest non-selective beta blocker that we use is propranolol, and it is also used for other things like migraine, for anxiety and increased tremors. So how does the beta blocker work? When it acts on the beta 1 receptor, it decreases the heart rate, it decreases the contractility, it decreases the cardiac output and also inhibits release of renin. The beta 2 blockers act on the peripheral blood vessels, causing peripheral vasoconstriction and bronchoconstriction. So the other uses that I said of propranolol in anxiety or in migraine, it's usually said that there is increased dilatation of the peripheral blood vessels. So when there is a peripheral vasoconstriction, it decreases the episodes of migraine. But another problem with beta 2 blockers is that it causes bronchoconstriction. So the non-selective beta blocker like propranolol, which has beta 1 and beta 2, increased overdose can also cause bronchoconstriction. And sometimes hence it's not also recommended in children with wheezing. So the clinical and lab features that will be there when there is beta blocker increased toxicity because of overdose will be bradycardia, hypotension, because it decreases the inotropy and chronotropy of the heart, and also because it can cause peripheral vasodilatation. Non-selective beta blockers can also act centrally, which can cause altered mental status. The clinical manifestations of beta blocker toxicity would be bradycardia, hypotension, altered mental status. And why does this occur? Because it causes decrease in heart rate, decrease inotropy, chronotropy. It causes peripheral vasodilatation. So because of that, they can have these manifestations. Non-selective beta blockers also have can affect the central nervous system and cause altered mental status. So clinical features we have said. Next, what would be the lab features? In the ECG, they would show episodes of bradycardia. There can be heart block. This non-selective, especially beta blockers, can also affect glycogenolysis and gluconeogenesis. So why are these required? These are required when there's decreased blood glucose levels. To increase the blood glucose levels, you need gluconeogenesis and glycogenolysis. These are affected in overdose of beta blockers, so the stored glucose cannot be utilized, and they can also hence present with hypoglycemia. So what would be the management of beta blocker toxicity? First, it's always airway, breathing and circulation. You have to see that the ABCs are right and appropriately manage them. Gastric decontamination, this can be done, and you can use activated charcoal also for gastric decontamination and bowel irrigation. The antidote for beta blocker is glucagon. It's given at 0.05 mg kg bolus, followed by infusions of 0.05 mg to 0.15 mg per kg per hour. For the decreased heart rate bradycardia, atropine can be given. Calcium is usually given during beta blocker toxicity to increase the contractility of the heart. When there are features of shock, vasopressors might also be needed. When there is a central depression or seizures presenting due to centrally acting beta blockers, benzodiazepines can be used for the seizure episodes. QRS widening can be treated with sodium bicarbonate. The duration of observation and stay for usually beta blockers is usually 6 hours. It's longer for propranolol and sotalol. Propranolol especially because it is lipophilic. Most of the other beta blockers are water soluble, and water soluble usually the toxicity can be seen within 6 hours, and the level of toxicity is usually lesser with water soluble compared to fat soluble beta blockers. So for propranolol and sotalol, the duration of stay might be longer depending on the clinical manifestations.